for a long time, they were developing different drugs for the brain and kind of ignoring the blood-brain barrier. They all knew it existed, but they'd say, well, it works in mice. We're going to use it in humans and hope that it gets there. And there is some leakiness around the tumor as far as getting the drug there. So they thought, well, maybe it'll work anyways. And now there's really a conscious effort to really understand, are we actually getting drug into the brain when we think we are?
Welcome to Didactic. I'm your host, Dr. O'Leary, and today is Wednesday, June 11th, 2025. This is a podcast about psychiatry and neuroscience that I've been producing now since December 2021. I explore topics about the brain and behavior that I find fascinating, and today I'm lucky to be able to provide you with an interview with a researcher in ultrasound, Dr. Michael Canney. Dr. Canney is an acoustics researcher and the chief scientific officer at a French company named Therapeutic, and they make ultrasound devices that can disrupt the blood-brain barrier in order to let in medications that otherwise could only get into the brain in very small amounts. We talk not only about this, but more broadly about the explosion of various applications of ultrasound beyond imaging, including things like tissue ablation, or basically cooking highly focused loci of tissue inside your body. Sounds like a good time, huh? Then after the interview, I'm going to review a few emerging applications of ultrasound to do things like temporarily turn neurons in the brain on and off. So without further ado, I give you Dr. Michael Canney. So Michael, welcome to the podcast. It's a pleasure to have you here. Just to get started, I'm going to ask you to introduce yourself to the audience. Who are you? Where do you come from? What are you doing right now that you find really interesting?
Awesome. Well, thanks so much for having me today on the podcast. I'm Mike Canney. I'm the chief scientific officer at Therapeutic. We're a French medtech company that is developing an ultrasound device for delivering drugs to the brain. And I think something that we'll get into a little bit more today.
Yeah. How did you get into ultrasound?
Yeah, so my path into ultrasound started quite a long time ago. When I was an undergrad, there was a strong acoustics program. So acoustics is pretty general field of study about, whether you're designing a symphony hall or building an instrument or doing something with ultrasound we'll talk about today. But there was a lot of professors working in this field when I was an undergrad at Boston University at the time. And I got involved in research my senior year with one of those professors and started a project in this field and went on to study it in my PhD as well at the University of Washington in Seattle.
And when people hear ultrasound, I imagine most of the listeners are going to be thinking, oh, that's that thing you do that can kind of look inside you, like maybe look at at a baby or look at your kidneys or something like that. But that's not what you do, is it? What do you do with ultrasound?
Yeah, so we do something very different. We don't use ultrasound for imaging, but we use it for its therapeutic mechanisms. And this has been an area that's been exploding, I think, over the past couple of decades, really, even though it's a field that's pretty old. It goes back to, the 50s. There's some pioneering work in the field. But really, there's been a resurgence, a lot of interest. But we're going to talk really about using ultrasound to enhance drug delivery to the brain today.
So that's what your work is, to try to get drugs into the brain. Let's take a little bit of a broader view before we get directly into that. I started to look into this, and I was fascinated by the different things that ultrasound can do in the body. And there were some fun words like cavitation and microbubbles and all sorts of things that I came across while I was reading about it. Can you explain some of the various ways, or actually maybe what does ultrasound do to the body? What is it capable of doing? And then what are some of the ways that we can use that in medicine or other kinds of therapeutics?
Yeah, so we can use ultrasound for all kinds of applications now. I think we mentioned the oldest one is imaging. This is what people think of first. I think the second most common application of ultrasound that people may have encountered is lithotripsy, which is used for bringing up kidney stones and is actually using an acoustic shock wave to pulverize and kind of break up stones non-invasively in the body. That's been around for a very long time. But here we're going to use ultrasound in different ways. And so another word that's thrown around is HIFU, which is high intensity focused ultrasound. This is using ultrasound for therapy and is really, you can think of it as turning up the power on your ultrasound device by, 100-fold or so or more. And so you can actually locally heat tissue and replace surgery in some applications. So you don't have to use a scalpel to cut out tissue. You can actually ablate tissue using thermally cooking it, basically, just like you would an egg on a skillet, for example. When you cook an egg, you basically denature all the proteins and kill everything. But you can do the same thing in the body with ultrasound, actually. And ultrasound has this amazing effect in that you can focus it down to very precise focal regions. So if you use ultrasound, you can get a focus that's on the order of a grain of rice. And so you can actually control where you're putting the energy within a very small region, and then very precisely, ablate tissue. This is one thing we can talk about, which is thermally ablating tissue. You mentioned a lot of things before this, which is once you start putting bubbles in, you can start getting all kinds of cool effects, which is the interaction of ultrasound with bubbles is cavitation, which is a whole nother thing and is somewhat related to what we do with drug delivery.
It sounds like ultrasound could be used for lots of things that it really hasn't been deployed for in a large way yet. And it may be able to replace certain things, like for certain tumors. Maybe it could replace radiation, ionizing radiation, which has a lot of other problems associated with it. At least maybe in some cases could be effective at either ablating tumors or maybe helping deliver drugs directly to the tumors. I was reading something about a tumor blood barrier, that sometimes the tumors themselves are kind of blocking the delivery of drugs to the tumor, and that you can directly open that barrier with ultrasound, similarly to what you guys are doing, which is opening up the blood-brain barrier to let medications get into the brain in order to help deliver chemotherapy to tumors in the brain.
Yeah, exactly. Like you're saying, I mean, there's a lot of different mechanisms you can employ. And so you can't actually use ultrasound to kind of trigger delivery of a drug within tumors. And there's really no commercial applications of that yet, but there's a lot of research going on in kind of how do you locally get drugs. But the problem is all the same. I mean, if we just back it up for a second and think about, well, any drug delivery, but if we talk about chemotherapy or something, normally you have a tumor sitting somewhere, and we give the drug, intravenously, and maybe a couple percentage of that drug that you're actually giving to the person is getting to where you want to get it. And the rest is causing toxic effects. These are all the adverse effects that we get of giving a drug. That could also be outside of oncology for any drug, but it's a big problem. How do you maximize how much drug you get to the tumor versus you get to the other tissues? Because once you can do that, you can really avoid the adverse, effects of a drug.
In this case, you don't have to necessarily develop new medications to treat tumors. We have some effective medications, but they're less effective because they're not maybe getting to the tumor. And so this can take already effective treatments that we have and enhance their effectiveness.
Yeah. So if we get back to the brain, we'll go back to the brain, and we'll say, so if we have a brain tumor, we even have a bigger effect than we talked about. If you give a drug IV and you have a tumor somewhere in the body, you might have, I don't know what the number might be, a couple percentage or more of the drug might actually get to that tumor and, kill those tumor cells. But in the brain, we have something called the blood-brain barrier, which is a very protective layer around all the vessels that prevents any drugs from getting into the brain, almost any drugs. So there's the numbers 98, 99% of drugs just don't cross the blood-brain barrier. And it's really dependent on the molecule size. So some small molecule drugs can cross the blood-brain barrier and get there. And there are some chemotherapies and other drugs that cross pretty well the blood-brain barrier, but a lot of other drugs that are in development really don't. And so once you're start getting into larger drugs, antibodies, which are used now for a lot of therapies, the numbers like 0.1% of that antibody is getting across and getting to where it might actually have a therapeutic effect in the brain.
Yeah, and I was also reading a little bit that if you can attach drugs to antibodies, they're more stable in the brain. So they stick around longer. They have an effect for longer on the tumor itself. So if you can get those antibodies into the brain, that might really help compared to just getting the drug itself into the brain.
Exactly.
Describe the device that you guys use. What does it do exactly? Maybe what does it look like? How do you make it work in the brain? And what is it doing when it's doing its job?
Yeah, so the device is very unique, and I think it was an innovation of the founder of the company, a doctor named Alexander Carpentier. He's a neurosurgeon based in Paris. And there's a lot of companies developing ultrasound devices, a lot of interesting developments around developing ways to cross the skull bone. And so the skull is a big limitation for trying to get ultrasound energy into the brain because it really blocks the ultrasound. So, 90% or more of the energy is basically being blocked by the skull. You can get a little bit more across at lower frequencies and things, but you still have some heating of the skull bone and other issues that you may have to deal with if you're trying to get ultrasound across the skull bone. And so this French neurosurgeon who founded the company, went to some conferences and was thinking about it. And he said, well, for brain cancer patients that I'm doing surgery on, I have to open up the skull bone and take out this bone flap anyways. And so when I take out the bone flap that I'm actually removing to get into the brain to do surgery on these patients, why don't I just put an ultrasound device replacing that bone flap? And so this is what the idea that he came up with. And so we've developed an ultrasound device that's implantable, and it can be used very simply by a neurosurgeon because it's using everything they're very used to. And so when they do surgery on the skull, they typically use like a titanium mesh to close up that bone window. And so we did the same thing. We have a titanium mesh, but just underneath the mesh, we have ultrasound transducers that are basically in direct contact with the brain. And so we don't have to pass ultrasound energy through the skull bone. We can just actually apply ultrasound directly to the brain. And so that leads to a lot of advantages because we know how much ultrasound energy we're delivering to the brain. So we don't have to worry about adverse events as much. And using that technology, basically, so we have this ultrasound implant. I mentioned it's basically doesn't have any power source, for example, because it's MR compatible. So it just plugs in using a small needle that passes through the scalp that you use to plug into the device, plug into an external power source, and to turn on the system. And this kind of design really makes it easy to use because there's no big equipment that a hospital has to buy, for example. And what happens is when you want to use this device to do drug delivery to the brain, a patient comes in, they go into the infusion suite to get their drug like they normally would get. And once they get their drug, they can have the device activated at the same time by the nursing staff that is there at the hospital. So we just turn on ultrasound for 4.5 minutes, and that's enough to disrupt the blood-brain barrier and to basically increase the concentration of drug within the brain tissue.
Wow. So you can take advantage of the fact that the surgeons already have to do a very invasive procedure, and then this device can go in there, and after that, it's very or minimally invasive. It's just a little needle that you put into the area to turn it on.
Right. Exactly. Yeah. Yep.
What kind of tumors are you guys investigating right now?
We're primarily treating glioblastoma, which is a type of very aggressive primary brain tumor. And the clinical trial we're running right now is a phase 3 clinical trial in patients who have recurred with glioblastoma. So they've come in and had their normal treatment, which you mentioned radiation. These patients typically will get a surgery, radiation, and chemotherapy as their initial treatment for this disease. And once the tumor grows again, there's not a lot of therapeutic options for these patients. And so at that point, patients can come on the clinical trial and get our device with another chemotherapy.
I was reading that you guys have definitely shown that it increases the amount of drug that gets into the brain and to the tumor. That has been established. I think that was in maybe phase 2 trials or I'm not sure how. Explain, because you guys got a designation called like breakthrough device, I think, designation from the FDA, which means that they're really excited about what you're doing and they want to fast track you through, I think. So explain that a little bit. What does that mean to get that designation? And then what's the process you've had to go through to get this device into where it is right now?
Yeah, I mean, so the FDA gives you that designation. We got it based on some of our phase 1-2 clinical data that showed that the device was safe, and we had some promising phase 2 results. And as you mentioned, we're also able to directly measure the drug in the brain, which is something that in the field of neuro-oncology, they always get this question now. It's becoming more common now when people say, how much drug are you actually getting to the brain? Because for a long time, they were developing different drugs for the brain and kind of ignoring the blood-brain barrier. They all knew it existed, but they'd say, well, it works in mice. We're going to use it in humans and hope that it gets there. And there is some leakiness around the tumor as far as getting the drug there. So they thought, well, maybe it'll work anyways. And now there's really a conscious effort to really understand, are we actually getting drug into the brain when we think we are? And so we did this study with a neurosurgeon in Chicago at Northwestern named Adam Sonnabend, who actually was able to use our device to disrupt the blood-brain barrier before he did surgery. And so patients that were coming on our clinical trials had the device activated to disrupt the blood-brain barrier in the OR just before he would go out and do resection of the tumor. We gave, low dose of chemotherapy drugs, and then you can actually take pieces of the tissue and actually measure the drug concentration within that tissue. And by doing that, we got, very interesting data because it confirmed everything we had learned from preclinical studies, which was that we had about a 5 to 6-fold increase in drug concentrations in the brain when we disrupted the blood-brain barrier. And we confirmed that in human patients. So this was very exciting to see the same thing.
Yeah, that is actually very exciting because the chemotherapeutic agents they are toxic. That's what they're supposed to be. They're supposed to kill cancer cells, but that means they also affect other cells in the body, especially the faster growing ones. And if we could reduce even the dose of that medication we can give to people, because we know that it's actually getting to the cancer, that might help them out a lot during the course of their treatment. And then you also reminded me of some other medications that I use. I'm a psychiatrist, and so of course we want meds to get to the brain, and one way to do that is just to give more of it, right? To give higher doses of it. So we often have to give doses that can maybe cause people some side effects, especially things like problems with their gut. And so if we can give less of it and give it in a more targeted way, that would be fantastic. Although we're not going to, I hope, have to cut their skull open. There may be other innovations.
Yeah, for sure. I mean, I think you point exactly to what has happened in neuro-oncology, which is, for a long time, I mean, you push the dose until you're having extreme adverse events and trying to keep the patient alive, but kill the tumor. And that's been done with a lot of chemotherapies, to try to make them more effective. And now we can actually, give a dose where the patients are okay, hopefully, and really increase the dose, the concentration locally in the brain.
Some people might be interested in how you make sound that affects tissue. Like you just put a little electricity in this thing and then it makes sound. Can you explain just maybe some of the mechanisms that are used to actually produce the sound and what, kind of hertz you're looking for? Like obviously patients aren't like hearing something, right? When you're doing this, it's not sound that they can hear.
Yeah, we're well above what you can hear. And so I think you typically can hear up to about 20 kilohertz, I believe, is the human hearing. The frequencies that we're using are around 1 megahertz. And so much higher frequencies than you can typically hear. And we use materials that are called, they're piezoceramic materials, basically. So you have a special material that you can apply basically a frequency to, and they'll vibrate and basically cause a mechanical displacement of the material in response to that.
Yeah, so in some ways, it's like a very focused blast wave. So with an explosion, you have the actual explosion itself, but you also have the waves that come off of it, the mechanical like waves that travel through the air and hit you as well. So it's kind of like that, only very, very fine-tuned and focused in the right area, doing the right thing.
Yeah, exactly. And I mean, it's a mechanical wave. And what we're harnessing, though, if we were just to apply ultrasound alone to the brain at the powers and frequencies we're using, there'd be almost no effect. There wouldn't really be an effect at all. And so how we really get a local effect is by using bubbles. So going back to cavitation, which you mentioned earlier, which is just really the response of a bubble to ultrasound. And so if you have a bubble of the right size, and in this case, we're using a 1 megahertz ultrasound system. So we have bubbles on the range of a few microns, which happens to be on the order of the size of, microvessel in the brain as well. Red blood cell is 10 microns, I think. And so those basically are squeezing through those microvessels. And so here we actually inject microbubbles that are on the same range. They're several microns in size. And these microbubbles are actually resonant at the ultrasound frequency that we're sending. And so when we send ultrasound energy, these microbubbles actually vibrate in response to that ultrasound. And that actually creates a local, you can think of it as a local kind of mechanical stress on the vessel wall. And that interaction of the microbubble with the vessel wall is what causes a disruption of the blood-brain barrier. So again, if we just applied ultrasound, there wouldn't be any effect. But this interaction between this bubble and the ultrasound, which is cavitation, is what really creates this effect on the blood-brain barrier.
That's pretty amazing that people figured that out, honestly, because the thought process I imagine to get from I can use ultrasound to shake something up to what if I put tiny little bubbles in it and use those to resonate the frequency in just the right place at the right time and the right size. I'm amazed at human ingenuity sometimes.
Yeah.
I was also reading that ultrasound is used because it can create heat. Like you mentioned, I think already, you can just heat tissues up with it a little bit. So you could, I think physiotherapists sometimes use it for pain relief or swelling in certain areas. They might just heat the tissue a little bit with some variable ultrasound. And so it's being looked at for things like that, or just heating up an area so much that the tissue, like you said, cooks. I imagine that's scary to people, but maybe they won't think it's so bad to have a knife cut it out as to think about it cooking inside them. I'm not sure which would be worse for them, but your body can clean it all up, and you don't have to actually introduce a foreign object into your body if you're using the ultrasound, I guess.
Yeah, that's the hope. I mean, that's the hope, is you can use ultrasound and replace a scalpel and just do something completely non-invasively. And that's a field that has had a lot of success. I mean, they're using it for prostate cancer, for example. They're using it in the brain as well to ablate different very tiny targets for essential tremor. This is an FDA-approved use of ultrasound.
Yeah, I think they call that a thalamotomy. So just in the thalamus, they just find out where the offending area is, and then just try to ablate that tiny little, like you said,
tiny part.
Yeah,
exactly.
Or for Parkinson's disease as well. I think that it can be helpful in different parts of the brain too, not just the thalamus. So in the pallidum as well. And then some people are trying to use it to help in bone fracture healing. I'm not sure what the mechanism is there, but maybe it helps activate some of the osteoblasts or other stem cells there to do their job. I don't know. When I was in med school, they would talk about when you're jumping up and down and actually walking and doing things, you're creating these little micro
stresses
in the bone, and that activates bone healing. And so, and by doing that, you're actually increasing the density of your bone over time. That's why they want people with osteoporosis to exercise and do weight-bearing exercises. So maybe it does something like that.
That could, yeah. There's some areas of ultrasound that's kind of the Wild West still, that people are using all kinds of things.
And so you're doing a phase 3 trial right now, is that correct?
Yes.
Okay. And can you explain what that phase 3 trial is going to do, and then what happens if the results are favorable to the device?
Yeah, so the phase 3 trial, we talk about the phase 3 is a randomized trial. And so the goal of the trial is to show that, our intervention is superior to the standard of care for these patients. And so the standard of care options, there's a couple of chemotherapies that they may typically give to these patients. And so we're doing the same thing. We're randomizing patients to either getting our device with a chemotherapy, or, what they would normally get anyways. And so the goal of the trial is to show that we can extend survival for these patients significantly beyond what they would, expect from what's out there right now.
I can imagine a review board, thinking about different ways that this could be done, and For example, do you actually implant sham devices in people, or are you able ethically to do that? Like, so it sounds like
Yeah,
a lot of considerations going into how you design this, because you also want it to be as exact as possible, but then you can't do certain things to people. So
yeah, there's a lot of constraints. I mean, what you mentioned, we're running a randomized controlled trial, but it is not blinded for people. And so unfortunately, for an intervention like this, we can't have a sham procedure for the patients. So they all know, we randomize patients about 3 days before they go into the OR to get the surgery. And so everyone is aware if the patient's getting the intervention or not.
yeah, and I can imagine ahead of time if you don't get the intervention. Just thinking as an ethicist here, because one of the I had in med school, I had a great ethics professor, and he would just make us just like think about everything. So I imagine going into, thinking, well, I'm not going to get the thing that might help me more. It could have certain effects on the patient themselves, right?
Yeah, I mean, I think you try to keep everything else almost identical between the arms. So we do imaging at the same time. We try to have the same number of hospital visits and things, because I think they do show, maybe there is some kind of placebo effect for patients being on a clinical trial just because they're getting more interaction, more care from the provider, that could have an effect. And so you do try to keep that equal, even for the patients that are on the control arm or getting the device.
And do you have any projections now as to how effective you think it's going to be? Like, it's not that you're going to cause complete remission, but that you're going to extend life and extend the quality of life over time, probably. Do you have any sort of estimations as what you would kind of expect to achieve?
Yeah, I mean, so what we saw in our phase 2 trial, which was with small numbers of patients, we had 12 patients in our last cohort, but the median overall survival was about 14 months for the patients that had our device, which seems short, but the for the comparator, for patients just getting normal therapy with recurrent glioblastoma, the overall survival is 6 to 12 months is the range that you see in the literature. So, we hope that this trial will be a first step towards showing, longer survival for these patients. The advantage, which you mentioned early on, is that we're not really stuck to one drug. So we're trying to show first with one drug that we can extend survival in these patients. And once we do that, I think that we can move to other drugs. And we have other phase 2 trials running with other therapies. And so you can imagine eventually a patient may get our device. My vision would be that eventually a patient would get our device when they get diagnosed, and then they may get different rounds of therapies depending on what could be the most effective at that stage of the disease or for that patient, that would push survival way beyond, several years. And so that's the future for the system. But we first really just need to show, hey, we can really have an effect with the drug. We can extend survival with this drug. And after that, we can start moving on to other therapies and build on that.
Yeah, I don't remember the exact numbers, but yeah, after getting a diagnosis of glioblastoma multiforme, the patients would be lucky to live another year in lots of cases. Adding, doubling, tripling that would be huge for them and for their families.
Yeah, that's right. Yeah, I mean, so you mentioned, I mean, it's probably still a year. I don't know. It's hard to say, because we look at the articles for patients who are all enrolled in clinical trials, and we look at their survival. And we know that it's kind of a handpicked, group of people that may have longer survival. But the standard of care right now, just to come back to that, it's been around for 20 years, was established in 2005, has not changed from a therapeutic perspective. And that trial really showed adding 3 months of survival to what existed. And so that's what is the gold standard right now for these patients.
You mentioned that you got interested in ultrasound in college. What various things have you yourself researched, more than just this one device? What have you been involved in that you found to be pretty interesting with ultrasound?
Yeah, all kinds of stuff. My PhD was more on using ultrasound to ablate tissue, kind of in a very vague sense, less related to a particular indication and more just looking at the mechanisms. And so, going back to the heating, I worked with some great researchers, and we looked at how quickly you could generate heat. And actually, we found that you could increase the temperature, for example, within a very small region by 100 degrees within a few milliseconds using ultrasound. So you can generate shock waves that actually heat tissue very rapidly. And this can create bubbles. Then you have the interaction we talked about with ultrasound with the bubbles that exist. And that actually turned into something else, which is we didn't talk about yet, but is a field called histotripsy, which is not using thermal energy to ablate tissue, but is using mechanical energy, and it's really using this interaction again between the ultrasound and bubbles that you create to destroy tissue. So you can pulverize tissue using this technique. And there's a company called Histosonics that now has been very successful in commercializing this for replacing the scalpel and doing non-invasive surgery for different tumors. I think they're focused on the liver, but there's a lot of different applications for this. So that was what my PhD was kind of around. We also had some other projects. I mean, you use ultrasound. We have ultrasonic toothbrushes, for example. And there was a startup company at the time that was trying to develop a competitor to the ultrasonic toothbrush that Philips makes, and we did a little bit of work with them. There was another company that was ablating fat, actually, called Liposonics that existed. So I talked about using mechanical energy from ultrasound to ablate tissue. They were trying to do that for, replace liposuction.
Mm-hmm.
Yeah. Another,
it would be nice if they could. During medical school, when I was sitting in on surgeries, some of them were liposuction surgeries, and like just watching it, I'm like, would I ever want? It turns your stomach a little bit, but I imagine, you could slowly, reduce body fat by just killing the tissue. I think one of the issues for people who do gain body fat is that even if they shrink the cells, even if they lose weight, significant weight, they still have those cells there that are ready to suck up fat really fast, so they can gain weight back really quickly. But if you could actually destroy the cell itself, then it would take longer for the body to rebuild and all of those fat cells. So they wouldn't be sitting there really sucking up the fat as easily, as quickly as they can already. That'd be pretty cool.
Yeah, I mean, I don't even know what happened to that company. I haven't followed up on it lately. But, I think that someone bought them, and maybe it still is possible to go and get that treatment. So, yeah.
And a lot of these, they seem like the machines are not necessarily, it's not an MRI machine, right? And it's safe, it's not invasive. You can go in, you could get multiple treatments in a lot of cases in short periods of time and not have to worry about having huge side effects in many cases. With ultrasound, some ultrasound can even fit in your pocket, I imagine. And so if you're thinking about in terms of being able to deliver medicine to people who can't necessarily make it into a bunch of appointments, older folks, things like that, ultrasound seems like a great way. I also saw like helping tissues to heal, softening up scars, activating, fibroblasts, collagen type all sorts of things. People are, I think it was something like 15,000 studies when I typed it into to see how many studies were registered. And all I did was type in therapeutic ultrasound, and I think it's like 13 or 15,000 popped up. Wow, that's a lot.
Yeah. There's a foundation called the FUS Foundation that kind of tracks this trajectory of using ultrasound for therapy, and it's like exponential, But it's great. I mean, it's what you mentioned. I mean, you can use ultrasound not just for the therapeutic effect, but also for the imaging guidance. And so there's systems that have the dual use. Like you said, you don't need an MRI. You can just image the tissue while you're also causing a treatment effect with the same device. And that's amazing, because MRIs are expensive and they're hard to get patients into. There's other ultrasound systems that will couple with the MRI, so you can actually use MRI to do monitoring at the same time. And you can use MRI. MRI is great for monitoring because you can actually monitor the tissue temperature in real time. So if you're using like a thermal mechanism, you can actually see what that temperature change is on the MR signal using some special sequences. But there's a lot of things you can do. Like you said, it can also fit in your pocket. I actually have an ultrasound imager here that plugs into your iPhone, and you can,
Right.
you can image using that. That's great.
Yeah, in my medical school, because it was Uniformed Services University, so it's a military medical school. We used a lot of ultrasound. We had lots of courses on it because it's so easy to bring in to the battlefield, and it's something that they just taught all of us. And every single one of our modules, we'd also have an ultrasound part with it. So we learned, how to do simple things like look for air in your chest cavity and compressing your lungs. We could look for abscesses. We could find blood vessels. We could look for foreign objects. We could, see if there's blood behind your bladder. We could do all sorts of things by imaging with ultrasound that are super important, like in the battlefield, to triage people, to look at their abdomen real quick and see, do we see any blood in there? Okay, if we do, that person needs to go first, things like that. So when I heard about you and I started reading, it was kind of exciting to me because I already had some experience with ultrasound and could see how cool it was.
Yeah. I mean, ultrasound imaging has come a long way too, like you mentioned. I mean, there's all kinds of new ways of using ultrasound for imaging that have been developed too, that make it, competitive with other imaging modalities.
Before we kind of wrap things up here, what else are you guys working on right now that you think maybe is different than this particular project, but seems to have some potential?
We're working on our pivotal trial with one chemotherapy, and we're also looking at other therapies. So we're working closely with Northwestern. We have some trials testing out immunotherapies, which I think are promising. They haven't shown a lot of effect yet, but we think maybe with our device, we can make them more effective in the brain. And so that's another avenue we're looking at. We're doing preclinical research. I manage preclinical research collaborations with, universities in the US and in Europe. And we have all kinds of preclinical projects going on, also looking at other new therapies that could be used with the device, that may make it even more effective. So we're continuing to look at that, at least for glioblastoma. And like you mentioned, there's also other applications. So we've been looking at ALS as a potential application, which is definitely a high unmet need for this disease to find new routes for therapy. And some of the drugs that are being developed also don't cross the blood-brain barrier. So they're still given, for example, intrathecally, or they're given into the CSF. And so being able to repeatedly give those drugs IV and use our device, could be a big advantage for something like that. And then, there's other applications. There's a lot of work in Alzheimer's that's really cool ongoing. So there was some paper published about a decade ago that was really cool in Alzheimer's in a mouse model that showed if you just disrupt the blood-brain barrier in a mouse model, you can get clearance of these amyloid plaques that accumulate in the brain. Without even giving a drug. And so you may have some therapeutic effects on the brain just from using the ultrasound alone. And that's something, we're still exploring.
Yeah, I ran across that too, and I thought that's awesome. I wondered about the mechanism there. Maybe it's just like stimulating a low-level inflammatory process that isn't harming the brain, but is just like waking some cells up, and they're being like, I got to clean some stuff up here or something.
Yeah, I think that's exactly what's happening.
Dr. Canney, Michael, I've enjoyed this conversation. I'm glad that I got introduced to you. And if you ever are excited about anything else, you want to come back and talk about it, I would be more than willing to bring you back on the show.
Great. Thanks so much for having me today. Yeah. If anyone just wants to learn anything more, I guess we do have a website for our clinical trial. It's sonobird.eu. That's our name for the trial, and we're recruiting across the U.S. and Europe into this trial for recurrent glioblastoma.
Did you spell that word?
Sonobird. It's sonobird.eu. And our company is Carthera, so you can also go to our website, carthera.eu, and learn more about that trial or other clinical trials that we're running.
Something I remember from earlier, there's a Dr. Sono Bend, is that right?
Sona Bend he's one of our, he's the PI of our phase 3 trial and a great collaborator.
Yeah, I was thinking about his name and I'm like, that's just the perfect name to be working on ultrasound, right?
Yeah, we get that a lot. Yeah.
I thought it was not real when I first read it. I thought it was like imaginary doctor and who we're going to call Dr. Sonabend because it was too perfect.
It is too perfect.
Yeah.
We're incredibly lucky to have an amazing collaboration with him and his team at Northwestern because, they've driven a lot of great innovations. He has a lab that has done a whole bunch of research with other therapies. And, we've learned a huge amount working with him. So it's been fantastic.
There's one more application of ultrasound that Michael and I did not talk about that I feel like I can't end this podcast without addressing, and it's neuromodulation. So similar to like transcranial magnetic stimulation or direct current stimulation of the brain, ultrasound can be used to encourage or discourage neurons from firing. A good recent review in 2023 was done by Beisteiner et al., and it's called Ultrasound Neuromodulation as the New Brain Therapy in the journal Advanced Science. So they discuss some of the experimental applications, and I really need to emphasize that most of these are very experimental clinical applications. There's not a lot of robust evidence for them yet. Therapeutic ultrasound for brain applications primarily utilizes two main classes of systems. One is a focused ultrasound system, or an FUS. The other is transcranial pulse stimulation. If you're using a focused ultrasound system across the cranium, you can call that transcranial FUS or TFUS. TFUS systems typically employ a single ultrasound frequency, just one frequency, and it's in the range of several hundred kilohertz, and it's delivered in pulses over several minutes to achieve their effects. This is very similar to the way TMS works, only TMS is using magnetic stimulation instead of mechanical ultrasound stimulation. The great thing about these systems is they can be worn on the outside of the skull, and they can often get pretty deep into the brain. At least one study they reported on used focused ultrasound on the thalamus in a brain injury patient to reportedly improve responsiveness. But it's also been used to try to reduce seizure frequency. So if you know where the locus of a seizure is, the onset of the seizure, then they've been able to use ultrasound to reportedly reduce the frequency of seizures in patients. They've also used it along with those microbubble contrast agents that we talked about earlier to target the right hippocampus in Alzheimer's patients, reportedly improving some of their verbal learning skills, and it resulted in changes that could be seen on PET scans. Now, aside from transcranial focused ultrasound, there's transcranial pulse stimulation, which uses shockwave technologies, really short kind of pressure pulses with different frequencies that are repeated 1 to 8 times a second for several minutes. But this tends to have more kind of irritation near and around the target of the ultrasound than the focused ultrasound. And it's been used primarily in Alzheimer's patients, reportedly improving their cognition scores, reducing brain atrophy, decreasing depression. And then also it has been used in patients with major depressive disorder and reportedly resulted in significant improvements on depression rating scales. However, I wouldn't get too excited yet. These are small studies, and what they're really doing is just demonstrating that it is practical to be able to use ultrasound for neuromodulation. Thank you for hanging out with me again today. If you would like to leave me any feedback, you can go to scydactic.com and fill out a form there, or you can just send me an email at info@scydactic.com. That's PSYDACTIC.com. Take care of yourself. I am Dr. O'Leary, and this has been an episode of Scydactic.